So hi everybody, really warm welcome to all of you. I know I say that every week, but I mean it. It's lovely to have your company. And I'm absolutely delighted today to be welcoming Dr. Jim Down. He's written a very compelling narrative of what happened in his hospital, which is University College Hospital in London, when the first wave of COVID hit, as an ICU consultant. So we're absolutely delighted and honoured to have his company today, and he's going to tell us really all about what happened during that first surge of COVID. So welcome, Jim.
Thank you very much for having me.
So my first question to you is quite a simple one. A year on, and we've come through effectively what is a second, if not a third surge. How are you feeling, and also what's happening in your hospital?
Yeah, so we're back to normal now, pretty much. We're back to normal activity. All the elective work's back in. It's more complicated because of having to have different separate pathways for different patients, those who've been isolated from COVID, those who come in as emergencies, all that kind of thing. So the logistics are more complex. But at the moment, we're in a period with no COVID admissions, which is obviously a relief. And I'm okay. I've had ups and downs through it. A little bit of a wobble recently, but I'm all right. And I think I do worry, though. I think that lots of the staff have been seriously affected, around the country. I think particularly the nurses, who had a really tough time trying to do their job in unprecedented circumstances.
Good. Well, I'm sorry to hear that you've had a bit of a wobble, but I think that's probably inevitable given what you've been through over the last 14 months or so. It must have been absolutely, well, some parts of it must have been absolutely dreadful. Tell us a little bit then, to begin with, if we go back, back to that first surge of COVID back last March. Tell us how you had to respond and adapt everything that you were doing in order to cope with what was happening.
Yeah, so I mean, as it approached, I think there were two things that were on our mind mainly. One was the scale, the number of patients that we were going to admit, and at that stage, it was really there was no ceiling, there was no limit to how many might come in, because we didn't know what the response was going to be, whether we were going to go into lockdown, all those kind of things. And the second was, before it hit, was safety of the staff. How were we going to protect the staff and get used to wearing PPE and working in PPE? And then, so we sort of prepared those two elements. We tried to work out where we'd expand and how we'd focus new staff to working in ICU, and how we get equipment and all that kind of thing. And then when it did hit, we realized what a terrible disease it was, what a much worse disease than we'd expected, and there was the learning and dealing with the new disease element that followed.
I'm very interested in the progress of your knowledge, really, that your understanding of this disease. So can you tell us a little bit about that? So from the first point of encountering COVID to what you then subsequently learned to now, it's like that must be quite an interesting arc of understanding, as I say, and being able to respond appropriately. So tell us a little bit about that from the beginning.
Yeah, so I mean, at the beginning, we were thinking of it as a spectrum of mild disease. Some people almost asymptomatic, through this sort of horrible flu type illness, and then to a respiratory failure, to a inflammation of the lungs, and that's what we understood to begin with. And there was this whole dilemma coming out of Italy about whether you put people onto formal ventilators early on, or whether you kept them on the tight CPAP masks, and no one knew the answer. And it was quite a strange time, because everyone was treating this one illness, but everyone was taking different strategies. So we went down the CPAP route, and other big hospitals, or most hospitals, went the other way, and that was quite a daunting thing. And we were just sort of learning on the hoof about when you had to change over from one to the other and all that kind of thing. And there was great collaboration across hospitals. You know, people were noticing one thing and then they'd share it among everyone, and we'd all say, oh, actually, yeah, that fits with what we've done. So there was an amazing sort of spreading of information. And very quickly then it became clear that in some people, it hit them with this enormous, overwhelming sort of inflammatory reaction, and they became incredibly hot and all their systems shut down. And we had, I talk about one of those in the book, a very young man who was overwhelmed by it. And that was a complete shock to me. And that was the moment when I sort of realized this was not, you know, a straightforward lung illness. And then gradually more things came through. Then we saw the blood clots, and we saw that these people had far more blood clots than most ICU patients. And then we saw that their brains were affected, and then we realized that about 20% of them got kidney failure. So it gradually built up. And then alongside that, there were these lots of studies going on, trying to, you know, in the most pragmatic way possible, try out drugs, most of them old drugs being tried, you know, for a new illness. And out of one of those came the dexamethasone, the steroid story, which made an impact, not a huge impact, but an impact. And then later another drug came through. But of course, in amongst that, I think they targeted something like 400 molecules in the process. So a huge number of them were not working. And it's kind of demonstrated how difficult it was. There were two drugs being trialed that had exactly opposite effects. So one had a positive effect, one had a negative effect. And because we just didn't know which was which would be beneficial overall. So it was a sort of time of sort of a bit like the vaccine, I suppose. Just everything was accelerated hugely.
Yeah, it's really good to hear, though, the degree of collaboration between medics and scientists and so on. I think that's the big story, really, which is where the vaccine has come from. But that's really, really good to hear. Would you say that in the second surge, if we take the second surge being from January of this year through to whenever you feel that peaked and declined, that there were considerable differences in the way that you were approaching treatment?
So that we were much better organised and prepared. So one of the big problems with the first surge was equipment. We normally have 35 ICU beds in the building I work in. We went up to 80 patients in the first surge, went up to 120 at peak in the second surge. And so we were putting them on ventilators that don't normally ventilate ICU patients, and being ventilated for an operation is a very different thing to being ventilated if you're very sick. But by the time of the second surge, we had enough of all the equipment pretty much. And we were better, we organised the staff better, we deployed medical students and all those kind of people much, much more efficiently and effectively. But the illness was still awful, and that was a real, I found that difficult, because I thought the second time round we'd be better at it and we'd be able to keep everyone alive, but of course that was, far from the truth. And that was that was a shock, I have to say, in some ways.
I mean, you've just come more or less through and toward, hopefully, out of that second surge. So, how are you right now? How have you been feeling?
Yeah, I'm okay. I've definitely had ups and downs with it, I think most people have. I think the nurses particularly have really, really suffered. They of all the groups, I think they had the hardest time, because they usually look after one ICU patient. Mm-hmm. Suddenly they were looking after 3 or 4 with helpers, but not trained helpers. And not only that, they were looking after 3 or 4 of the most sick ICU patients we've ever had. So the sort of load on them emotionally was huge, and then the pressure, and then they're so used to, one of the gynecologists actually came and helped out as a nursing assistant. He said to me, he just couldn't believe the amount of care that goes in every day to an ICU patient, because of course they're helpless. They can't blink, they can't swallow, they can't move, they can't do anything. So the nurses not only do all the technical, clever machine stuff, they also look after every detail, stop them getting pressure sores. keep their mouth hygiene, keep their eyes safe, all those things. And suddenly they were doing it for far more people than usual. So that was really tough for them, I think.
You convey that extremely powerfully in the book through conversations that you're having with nurses, and the way that you have to become more empathetic towards them and understand what the level of responsibility that they're having to take for these incredibly sick people. And they're having to split themselves into 3, 4, 5 different parts and try and be in 3 places at once, kind of thing. I mean, you convey that, as I say, very powerfully indeed. My next question is really about families, because this is, I suppose, for the people watching and listening to this, we would ever, well, unless we happen to come in as patients, but it's to be at the effect of this terrible disease at one remove. So we've got somebody who we love, who's extremely sick, who's in hospital, and suddenly we can't visit them, we can't see them, we can't talk to them. So how did you deal with that? Because that must have been really challenging.
Yeah, so that was again a thing that we hadn't really taken on board until it happened. And I remember very early a crowd of us sitting behind the front desk of the ICU on the phone to relatives, and we were all lined up, and you couldn't really hear very well. And I suddenly thought, God, this is awful, And normally, of course, they'd be at the bedside. People are often in ICU, every day if they're family members there. And so not only do you have it's quite easy to communicate with them. Also, they give the patient who's asleep, and so you haven't been able to talk to, they bring them to life, if you like. They give them a personality, you learn about them, they bring in pictures, all those kind of things. And all that was gone. And there was a big hit in terms of just them being able to see their families, but also communicating on the telephone is obviously really difficult when you're having to convey such serious news, and often that news would go on for weeks. Every day you'd be saying, well, I'm afraid still really sick. And so that was really tough. So what we in fact did was set up a big team that were purely, all they were about was liaising with families, and they'd make sure that a phone call got through every day, make sure that all the questions were answered, and then they'd set up visits with the patients, and they'd either do a telephone visit if the patient was awake, or they'd do a video visit, so they could take an iPad to the bed space, and the patients could then see, the relatives could see the patient, even if they were unconscious on a ventilator, and they could talk to them. And I was, initially I was very sort of puzzled by this, almost a bit skeptical. But then when I saw it in real life, it was an amazing thing to see. And you'd see a whole family, talking away to their relative, just like people do normally, I suppose, when they come to see the patient, even if they're unconscious. But it was, so I think that was a really positive move. And then when we could, we let people in for, if there was some, for special events or whatever. But it was difficult.
Yeah, I think one of the things that I've gleaned from various television programs that I've seen, various things that I've read, is the degree to which, the trouble to which people like you went in order to ameliorate this terrible situation where they couldn't have visitors, and also that, to give terribly bad news in a way that is not how you would normally do it, because you would normally expect to be in a family room and do it sensitively and supportively and all that kind of thing. So there were all sorts of things about this terrible, terrible situation which were challenging and difficult. And I think, as I said, the impression that I get is that you did everything in your power to make that better in whatever way you could. So.
Yeah, and we did bring people in for, if we thought that someone was dying, we'd try and bring people in. But of course, not everyone can come in, if they're shielding. So it's never, it wasn't straightforward. And it was one of the, it was one of the worst things in many ways about it, was the families being stuck at home, I think, and not being able to be at the bedside. Absolutely.
And that brings me on to 3 people that you concentrate on in a way in the book, 3 stories that you tell. They're all very sad stories, because they're all they're all people that succumbed to COVID, but they make the book very powerful. And I think they're important because we need to hear these stories. So tell us a little bit. There were three. So there was Adam, there was Jonathan, and Tricia. So tell us a little bit about anything that you want to tell us really about any of those three or all of them.
Well, so I've already mentioned Adam was the young man at the beginning, and he just had this terrible reaction, this sort of idiosyncratic reaction to COVID, and that was just very shocking and really woke me up to how terrible it could be. Jonathan was a man of 40 who just come through a bone marrow transplant, and then caught COVID, and so he was very weakened by his bone marrow transplant, and he really struck me because he was he was a very relatable chap, and he was very determined, and he stayed on his CPAP for about a week, really determined to fight it, and he really understood how serious it was, particularly for him if he went on a ventilator. And his wife was at home shielding with their young kids, so she couldn't come in. And again, speaking to her, I could just imagine meeting her at the school gates. Her kids are similar age to my kids, and it was all. And she was so, I remember the conversation they had through the iPad when just before we had to put them on a ventilator, and they were both so sort of brave and yet supportive and loving, and it just completely just knocked me for six. And then he was on the ventilator for a long time, but unfortunately he didn't recover. And I've spoken to her since, and she's amazing. She's doing really well, and the kids are okay, and we're going to hopefully at some stage we're going to meet up. It was just. I don't know why some people really catch you. I don't know if it's because you recognise something, but there was something about that couple that really moved me.
Yeah. And Tricia was a senior nurse, a very senior nurse at Great Ormond Street Hospital. She was 60. So she was at the height of her profession, lovely family, and she had a 17-year-old, a 23-year-old, I think, and she caught COVID, and you also treated her. So tell us a little bit about that, because you've been in touch with the family since.
Yeah. So I mean, a lovely family, and I think the thing with her was that she was just full of life, and one of the she worked at Great Ormond Street, and she sort of embodied the place. She was devoted to it. Her husband talked about it being her second family, and she was sort of kind of fearless, and I can imagine her. I mean, I never worked with her, but I can imagine her at work just being one of those people that got everything done and took no nonsense, and I think she was converting Great Ormond Street into a unit that could take patients from other hospitals just before the COVID surge. And she was very different to the other two in that she just relentlessly declined over weeks. There wasn't she wasn't like Adam, where it was very dramatic and sudden. She just got gradually worse, and that was very upsetting, because you sort of kept thinking we must be able to do something, but there were some people, unfortunately, there was just nothing we could do. And her family are just delightful. And I've spoken to her husband, for quite a long time over the months, because one of the unique things about writing the book was that I've talked to families and patients. In fact, there are lots of survivors in the book as well. I do want to make that clear. But I've spoken to lots of them, 6 months later, to get their permission to write about them. So I've seen people that normally I wouldn't have seen, after they'd left ICU. So that's been really educational for me. And
you found out that Tricia's daughter is what's happening to her?
Going to medical school and is going to become a paediatrician. So that was wonderful. She rang me actually to say I've been asked to. My interview question is the ethics of a pandemic, and I thought, that is so. That's not fair on you. But anyway, we talked about it, and she's going, so that's terrific.
That's absolutely brilliant. And actually, that's a good lead into my next question, which is about ethics. Something that I was very interested in from your book. Ethics being the situation where you have to really give great consideration to what is happening with people in your care, and the sort of choices that you are being given responsibility to make from time to time, choices about who gets what. In what might be an allocation of resources that aren't as, as full as you'd want them to be. So my question really is, how did you go about making those very difficult decisions that sometimes you were faced with during that first surge?
Yeah, so I think we were quickly aware that this might be different to normal. Not just because of the numbers, but because it was a new disease. And so making those, so we normally run a sort of fairness ethical parameter where, everyone is treated. If the feeling is that you can benefit from ICU and the benefits outweigh the burdens of the treatment, then we offer it. That's sort of roughly the principles. But in a pandemic, of course, that might shift to a benefit system where, who can benefit most from the treatment. And then it becomes much more complex and difficult, because you get into, percentages, potentially age, quality of life, all those kind of things that are really, really subjective and controversial and difficult. So that was in the back of our mind. But there was also this issue that how are we going to make these decisions, about with a new disease, and how much would that affect, well, obviously the patients and us. And we quickly decided that we shouldn't be doing that on our own. We shouldn't be coming to decisions where we felt things were hopeless as a single practitioner. So we set up a three wise people system. And every time we felt that one of the patients we were looking after was coming to a point where it was becoming futile, we had a conference, and then we go through the case in detail. And between the three of us, and all three had to agree, had to be a unanimous decision. And that was incredibly helpful, because often just some fresh eyes coming in are less emotionally sort of involved, and can see it with a different eye. And often decisions were changed or moved because of that. And so we kept that throughout. And then we also set up other groups beyond that if things got really complicated or controversial. I'm sure, anything like this, well, I think it's very difficult to be making perfect decisions all the time, but I think we tried our absolute best to get it right as much as we could.
Yeah, I found that part of your booking immensely reassuring. The fact that you set up this three wise person system, and that no decision was taken lightly. You took it extremely seriously. Of course, it's an extremely serious situation. Why would you take it lightly? But I think it's very reassuring. I also think, for our audience, talking to our families about what we would want in that situation. This is something you referred to. Sometimes you'd say, what are the families saying? Has the person expressed any view about this, what they would want? Would they want it, a DNR or a whatever, the situation to be let go rather than to be fought and possibly compromised dreadfully as a result. So I think that, as I said, with the audience watching, we all ought to have these terribly difficult conversations with our families, so that they know exactly where we stand. I'm certainly very keen on that, though I know some people aren't very keen on it at all. But I think the way that you handled it was, as I said, it's extremely reassuring. I think one of the other things I'm interested in is the sort of longer term impact that you feel that there is or likely to be on you yourself, possibly on staff within the NHS. And of course, there's longer term impact on the patients. We're learning more and more about long COVID and things like that, and also on the NHS. So any thoughts about that?
Yeah, I mean, it's definitely had an impact on me, and I think a lot of my colleagues. And I think a lot of us are sort of coming to terms with that. I hope it'll all settle down. I think in terms of the it's interesting in terms of the NHS, in terms of ICU. In some ways, lots of people have come to work in ICU who never would have, and some of them have stayed. So in some ways, just like I think nursing recruitment's at an all-time high at the moment, because people have suddenly, it's gone up the sort of hierarchy of value or whatever. So there is a sort of slightly counterintuitive bounce on those kind of things. I think also there will be a positive legacy in terms of the number of ICU beds. So traditionally we've been low if you compare us with Germany and the States and many other countries, and we're certainly expanding, and my understanding is the numbers nationally expanding. So that is a positive thing. But of course, the backlog of work is not good. I mean, we did, as I mentioned, the private hospitals took on a lot of cancer work, certainly around where I work, and did a huge amount of cancer operations. So many of those were kept up with, but there's an awful lot of people who need, joint replacements and those kind of things, and who've had a year of waiting and getting less fit and more pain and all that kind of thing. So there's a big problem there. And then long COVID, I mean, I'm not an expert in long COVID at all, but clearly it's a very debilitating illness, a very broad range as far as I can see of symptoms. And we've got a big clinic, and I think the message is go and see someone if you've got the symptoms, because they are doing wonderful things.
Absolutely. In fact, today, Anna and I have been discussing, and we've approached Michael Rosen to be on a talk with me. I think you're probably aware that Michael Rosen got COVID very badly and was intubated and was put to sleep and was very near to death, I think. And then he recovered amazingly, and he's written this wonderful book. So be a great pleasure to interview him sometime in July, I hope. So we'll have the other side of the story, really, the patient side of it, having had yours, which has been wonderful. Just to say, there are a couple of lighter things in your book. One is your wonderful family, especially your twins, who I think are about 11 or 12 years old. They're about the same age as my grandson Patrick. So they're fairly irreverent, and that seems to have helped you quite a lot.
Extremely irreverent, yes. And they were a great, I mean, in fact, coming home was brilliant, because we didn't, some people obviously stayed away from their families, and we made a decision early not to, rightly or wrongly. But it was, for me, it was the lifesaver. My wife was just incredibly just carried on as normal. She's much less prone to anxiety about these things than I am. And the kids were great. They sort of did some homeschooling, I think, but not, I mean, it was touch and go. But the funniest thing was the clapping. They used to come out and sarcastically clap me on Thursdays. On the floor, sort of half asleep, and it just really kept me going and brought me back to normality.
I absolutely love the idea of sarcastic clapping. They've obviously honed it to a T. They're the perfect sarcastic clappers, as I can imagine a lot of 12-year-olds being. Anyway, that was absolutely wonderful. I really enjoyed that conversation with you. Thank you so much. So Emily, I'm going to come to you. So let's have the questions, please.
Fab. So we've got the first question from Kathy. She is in the US. She said, "Can you compare the difference that you've seen between the US and Europe?"
Oh, well, I'm not that's a very good question. I don't know much about the US. I mean, I saw that there were some horrible outbreaks. Well, obviously in New York at the beginning, but I have to admit, I don't know. I don't know enough about what the instance was in the States through the two pandemics. I mean, obviously we got all Trump's proclamations on it, but I'm afraid I'm probably no better to answer that than anyone else in the room. I'm sorry.
No, that's absolutely fine.
I had Kathy in my group, in fact, who asked that question, and we've just been having a chat about it. So she was saying that at the moment, she lives in Wisconsin, there are absolutely no, there's no sense in which there is any pandemic at all. Nobody wears, nobody's mandated to wear masks, so they don't, and also, nothing is being shut down or anything. So, and she was saying that, that the response has been not at all the same as it has been in Europe, let's put it that way.
I think it's really interesting that the Southeast Asian countries respond in a totally different way, don't they? They all just go masks on immediately into virus mode, and they, I think because they're culturally used to, they've seen it before, and I think the Europe and probably the States even more, we're just so culturally averse to sort of being told what to do. Although I mean, obviously in the UK people did do what they were told, which was amazing. But I think it was a much bigger leap for us. Yeah.
Emily, another question.
The next question is from Jackie. She said, "Do you think that the Indian variant will cause a third wave?"
Oh, I hope not. I don't know. I mean, I'm just watching the news like everyone else. I'm encouraged by the vaccine. I think the vaccine is an extraordinary achievement in this country. And I mean, I'm just watching the telly like everyone else, but it seems that it's effective. So it's really down to how fast it's spreading. And I don't think we know that yet. So there are some models, as I understand it, that say a smaller wave in the sort of late summer, but whether that will happen seems to be very much up in the air at the moment. I think, as far as I understand it, it's down to how much more infective it is, as it were. But we're all like everyone else praying it won't, really.
Absolutely. The next question is from Jenny, who asks, "How did you all deal with the amount of new information that was flowing?"
Yeah, so I'm very lucky. I work in a teaching hospital in the middle of London, surrounded by professors, and nice professors, not the bad kind. And so right from the start, one of our profs rang 12 of his prof mates in Italy and got as much, he asked them 15 questions, I think, and it was brilliant. So we were off almost ahead of the game. He asked them, what do they do, this, and then as soon as it hit, we had consultant meetings 2 to 3 times a week, and we would deal with everything in them. So we'd think about treatment strategies, we'd think about equipment, we'd think about where to build the next ICU, electricity, rotors, ethics. We just dealt with, in this group of about 20 of us, 25, we went through it, and we had a young guy who was just born to lead crises, and he just grabbed it and marshaled us all, and we all fell in. So we were very lucky that we had a couple of factors on our side, as it were, to take on the information, and then everyone fell into their roles. So that the academics were picking up all the information very quickly from around the country and talking to all their other academics, and one person looked after all the junior doctors and worked out all their rotas and brought in staff. So we just sort of split into these groups, and I just sort of milled around in the middle, checking everyone was okay.
And then the next question is from Joan. She asks, "Are you any closer to understanding why a fit young person may succumb to COVID more than an older person with underlying health issues?" And she also says, "Thank you for everything you are doing."
So that's a really good question, and the answer is no. We know that there was that the patients we saw had a very, the young person was a real outlier. So he was the only person of that age that we treated. We had some people in their 30s and 40s, but he was a real outlier, and he had a very idiosyncratic reaction to the virus, which was, there were cases around the place, but not many. We tended to see people with with the illnesses that you hear about, the diabetics, high blood pressure, people with obesity, that was quite a strong feature, and much more men than women. That'll be popular, won't it? But of course it wasn't. They weren't all like that. And I think there's something about the inflammatory response that people have that is linked to high blood pressure and diabetes that makes you react to these viruses in a worse way, as it were. But I don't claim to know what that is. And there was a brilliant picture of the virus and a receptor and all the different places that people were trying to work out, if they could make it better. There were hundreds and hundreds, and I mean, it was just well beyond me. It's so complicated.
Yeah, absolutely. Sandra asks, how were you able to go to work day after day and avoid catching COVID? Were you scared to go to work every day?
So I was, yes. I'm not. I used to have nightmares as a child about running away from battlefields. I'm not a brave person by nature, and I worried about it in the build-up, particularly. And actually, funny enough, there was once I'd put on the equipment and gone into a bay full of people with COVID, it was almost a relief. Because everyone was just getting on with it. So they all looked funny in all the kit you've seen, but they were doing their jobs. And suddenly you thought, oh yeah, no, we can just do this now. And then gradually it became more and more clear that the PPE worked. We were very lucky. We had really good PPE, and so we began to trust it. And then it became that very quickly drifted out of the consciousness, really. We start to believe in it, and actually I felt safer in the PPE in a COVID bay than dodging people around Hampstead Heath. So it was I was lucky. I mean, I think if I hadn't, I know obviously places didn't have PPE, and that was very, very difficult. And as far as I can tell, I haven't had it at all, which is extraordinary, I suppose.
Miranda asks, it may sound daft, but were/are COVID patients suitable organ donors, or are their systems too compromised?
That's not daft at all, because I don't know the answer. I wouldn't have thought, if you've recovered from... Oh, you mean people who died of COVID?
I think so.
Yeah, sorry, no, their organs were too damaged, and also you wouldn't want to transfer the virus.
Yeah.
No, they weren't. Unfortunately, they weren't.
Sarah asks, would it be helpful if your patients decided whether or not they wanted to be resuscitated if their life was irretrievably compromised?
Yeah, so we try and ask that of everyone pretty much who comes in, and we ask them, if there's any things they wouldn't want, any treatments like being put on a ventilator or a kidney machine or whatever. And the more information, the better. In a sort of negative way, if you like, knowing that someone doesn't want something makes it much easier, because we're often wrestling with, is there a realistic chance of this person getting off a ventilator again if they go on one? I guess. Yeah. If there isn't, then it's not a treatment in itself. Being on a ventilator is not a life, as it were, unless you're awake and got tracheostomy and particular various things. But generally on ICU, it's not.
Yeah.
There needs to be a positive end to it.
And then the last question from Marilyn is, what would you say to somebody who refuses to be vaccinated?
Well, I suppose I have two things. The mask deniers, I find difficult, because I think obviously it's up to us what we do with our health. But the problem with not wearing masks is that you're risking other people, and unnecessarily, unless you've got a particular exemption from wearing a mask. And so I feel very strongly that that's not really acceptable. The vaccine, again, it's the same thing, isn't it? We need people to take up the vaccine to protect the people who can't have it. I mean, that's one way of looking at it. There's certain groups who can't be vaccinated, and they need everyone else to be vaccinated so that the disease goes away. And I suppose in many ways that's in some ways a very powerful argument in terms of vaccination. Measles, for instance, you might survive measles, but someone else who couldn't have the vaccine might die from it. So I suppose that those would be my arguments. I mean, I do get the anxiety with, I think it's more complicated for the 20-year-olds who have seen the complications, but of course, overwhelmingly, the benefits outweigh the risks. But I do understand the anxieties, but I just think we need to keep pushing the message that the benefits far outweigh the risks. And really, it's the only way out of this, isn't it?
Yeah, I agree. And that's the last question, Tricia.
Thank you so much, Emily. Have you been vaccinated, Tim?
I have, yes. No, I was first. In fact, the medical staff are all, climbing over each other to get there.
So you've had both doses, like me?
I've had both my doses, absolutely, yeah. First opportunity.
It's such a good feeling. I think people have been very moved and become very emotional when they've been vaccinated. It's strange, just the relief. I mean, it was obvious that the only way out of this ultimately would have to be through vaccination. And as you say in the book, at one point, it could be a million miles away, a million years away, but in fact, it is remarkable. I think we shouldn't ever take for granted just what a remarkable achievement it has been to produce a safe vaccine, because it is safe in the quantities that have been produced. So on which note, which is a hopeful note, go on.
I couldn't agree with you more. I think it's an extraordinary achievement. And it just, I mean, when everyone starts working on one thing, what they can achieve is quite incredible, isn't it?
As you've shown, and remarkable achievement. I would say, well, we should acknowledge the remarkable achievement that you did and your colleagues, because without you working in the way that you did on the front line in ICU and doing all the things that you had to do, then many more people would have died than did. And so I want to absolutely acknowledge you and what you've done, and thank you on behalf of everybody watching, but also on behalf of everybody that has been affected by this horrible pandemic, because, as I said, without people like you, we would be in a much more dire situation. So thank you so much for that.
It's been an absolute pleasure. Thank you.
It's been a pleasure for us as well. So again, thank you very much. And thanks everybody for joining us, and see you all again next week. Bye-bye.